Are you on the group? Hey? Oh, when did you join then? Because how did you get to know about today's? Okay, you must give me a number. I'll send you the invite to the group. Then you can watch all the older lectures and things. I've got a whole thing on yeah. So for the last month or so, we've just been refreshing everybody's mind when it comes to ECGs. And what I said we'll do today, just to cap off the month, because from next month I'll start with other topics, including ECGs. We're just going to talk about acute chest pain. All right. Now, when I say an approach to acute chest pain, I'm talking specifically in the emergency department. All right. We're not talking about in an outpatient setting or a clinic setting. We're talking about a patient who's coming in and who's really not well and has severe acute chest pain. What do you do? Because acute chest pain doesn't equal myocardial infarction. There's a lot of things that it can be. And even if it equals myocardial infarction, it still depends on how bad it is. Okay, all right? Okay, right. All right. So let's try and see what do we do. So we're talking about those first 20 minutes when your patient comes in. So generally when these patients are triaged, they are triaged as red codes and orange codes, all right? So red code meaning most serious, orange second, or a priority 1, priority 2, depending on how bad they are, okay? So normally what determines how bad they are, their vitals, low BPs, high heart rate, or severe pain, or whatever it may be. So that's how they present. So now you have this patient, triage is a red code, complains of acute chest pain. What would you do? You don't have to be right. Give me any answer. What do you think you would do? Sorry? Very good. Oxygen? BP. So get all the vitals basically, right? Anything else you would want to do to investigate this patient and see? Okay, even before that, is there a machine you can use? Very good, ECG. All right, so the first thing you need to do is an ECG, because the ECG will guide you as to whether there's something wrong, The reason being, let's say you take cardiac markers and things like that, but it's actually a pneumothorax. You wasted now about 2,000 to 3,000 rand, just for nothing, yeah? So the first thing that you do is you do an ECG, all right? And then you follow this algorithm. Now, can you see how huge this algorithm is, all right? So it's not fun to sit and study all of this, all right? So what we're going to do is we're going to try and break it down into little itty-bitty pieces so you understand how each one works, all right? And when you have a chance, sit with it and see, all right? But like this is, for example, the EMRS, all right? What do they do? So we're going to start first with looking at the emergency department and what happens there. Okay, so let's start with that. So if you work in an emergency department, your job is to stabilize. No matter what it is, your job is to stabilize the patient, give a preemptive diagnosis. So the way you give a preemptive diagnosis is you stratify the patient into risk categories. So even before we get into the risk categories, what risk categories do you think there are for cardiac patients? High? No, I'm just saying the rest, like if you say high risk and medium risk and low risk. All right. So those are the 3 stratifications. All right. So that's what we're trying to learn today is how do we stratify them and what do we do? All right. So what do? You're right. 100% right. Check vital signs, evaluate oxygen saturation, establish IV access, perform a brief targeted history and physical exam. So in other words, everything that we do for any seriously ill patient that comes into the emergency department, that doesn't really change. If somebody comes in with a gunshot wound, you do the exact same thing. Agreed. You check their vitals, you make sure everything's okay, you put up a drip, you take bloods, things like that. All right. So the one thing that's different is that you complete the fibrinolytic checklist. All right. So the thing is, any patient who has potentially got a myocardial infarction or ischemia may need to be thrombolized. So thrombolysis means breaking down the clots that are present in those coronary arteries to get blood flow going. The problem is the medication doesn't know that it only needs to go to the heart. So throughout your entire body, it's breaking down clots everywhere, all right? So there are some contraindications to it. So let's say somebody's got a head injury at the same time, or has had a previous head injury in the last few months. I'm just giving you all examples. If you suddenly take away their ability to clot, they're just going to start bleeding free for all right? And if they got severe facial trauma, they may just start bleeding, all right? Or any severe bleed, okay? So that's one of the things that you have to look at, okay? Did they undergo long periods of CPR? Because then their prognosis is not very good. Are you going to thrombolize them as well? What if you have a CVP that you can't compare? So there's quite a few things. The whole checklist is in the emergency department, but it's nice to, keep, it's a very long list. So it's not easy to memorize. Some people do, but it's nice to just have it in some sort of a form. You either have it in your phone, the fibrinolytic checklist, or you look for it in your department where you're working. So basically you ask the patient or the family all those questions, and it tells you whether you can thrombolize them or no, and it takes about 5 minutes, all right? So we obtain initial cardiac marker levels, as you had said, electrolytes, coagulation studies, all of that, and a portable chest X-ray, all right? The portable chest X-ray is not because you can see the heart attack, but just because it helps you to rule out other conditions that may be going with it, all right? Then how do you treat? So you give oxygen, as you had said, all right? That depends on how much, you titrate it. You see how much you need, all right? Aspirin, half an aspirin, if it hasn't already been given. Now, TNT, yes, you do give, but if you guys remember, we had spoken before that if you have a right-sided myocardial infarct, we try and avoid it, okay? If it's a right-sided, okay? And then morphine IV, all right? If the discomfort is not relieved by nitroglycerin or TNT, but the majority of the time it won't be relieved by TNT if it's a bad blockage, okay? So our main weapon is the ECG, all right? So it's not foolproof. You do get people who come with normal ECGs, but they're having ischemia, all right? So like I say, once we have an ECG, we have 3 distinct parts, either high risk, medium risk, or low risk, all right? So today we'll just look at some simple ECG tracings, and we're going to identify warning things, all right? We're not going to go through each ECG step by step today because it's going to take too long. We're just going to concentrate on where the problem may be, all right? Now you need to know how to interpret ECGs. It's an important skill for all doctors, okay? Now these 2 books are actually very good, especially, if you don't have time to sit and listen to lectures, or you're more somebody who likes to read, ECG Made Easy, or the only ECG book you will ever need. They're available for free download PDF. So you can just keep it on your phone, read it when you got a chance. It takes you through everything step by step. Okay. So if you guys have a chance, try and get hold of those books as well. They're quite good. All right. So now we're going to look at ST elevated myocardial infarct. So what we call STEMIs. Okay. Right. So let's have a look at this. Now, can anybody name the abnormalities? We're not going to go through the whole thing, like axis, rate, rhythm, all of that, because like I say, it's going to take a bit long, but we're just going to look at where this patient may have had an infarct, all right? So let's assume that we know the axis. Let's say the axis is normal, rhythm is normal, rate is within normal. So now we're looking at each of the zones, all right? So where would you guys like to start? Let's say the inferior zone, all right? So leads 2, 3, and AVF are the inferior part of the heart. What do you notice there? Where's the ST segment? Okay, ST depression, very good, all right. So we have ST depressions. Let's come to leads 1 and AVL, which are the high lateral leads, all right. So they sit on the high part of the left chest, looking at that. And what do you see here? Very good, ST elevations. So you have ST elevations and you have ST depressions. The ST depressions are called reciprocal changes. Okay, so the infarct is happening here and the leads on the opposite side are seeing the opposite. Okay, AVR we can also look at, there's not much. Then we come to the septum, V1, V2. What do you notice here, especially in V2? ST elevations, very good. V3, V4, elevations again. And then V5 and V6, all right, here you even see a depression. But now you know that it's going to be in the anteroceptor and in the high lateral lead. So what are you going to call it? You're going to call it an anteroceptor MI plus high lateral MI, all right? Would you be worried if you saw this ECG? Or would you go for a smoke break? It's worrisome, isn't it? So this patient is having a heart attack. This patient is having a massive heart attack, actually, all right? It's involving most of the left ventricle. Okay, so the left ventricle is quite important, okay, because it's the one that supplies blood. Okay, to make it sound a bit simpler, imagine you are right-handed and we start cutting your blood flow to your right hand. Your left hand can try and do the work, but is it going to manage as well as your right hand? Definitely not. Okay. And vice versa if you're left-handed. Okay. So the right hand is the one that's providing power, that can do your writing. That's the equivalent of your left ventricle, for example. All right. So this patient needs to be treated very quickly. Okay. Okay, so there's all the changes that we are seeing, and then we take it from there. So we've made the diagnosis, all right. Now the question is what next? So we've said this is high risk. This is a worrying patient, all right. So the patient requires either thrombolysis, which is medication such as streptokinase, alteplase, basically anything that breaks down clots, all right, completely, or PCI. Anybody know what PCI is? Sorry? Yeah, percutaneous coronary insufflation. All right, what's commonly known as stenting. All right, so don't worry. Even if you remember PCI, nobody's going to stop you in a corridor and say, what do you mean PCI? We all know what PCI is. So percutaneous coronary insufflation. To put it quite simply, you do an angiogram and you see where the blockages are. You put a stent through that and then you inflate it, okay, to allow blood to flow. So when your family and friends now come to you and say, hey, I had a stent, you at least understand what they mean. Yeah, he's not stuttering while he's saying tent. All right, he had a stent. Okay, now we do give morphine as well. All right, so we give morphine between 2 to 10 milligrams, especially if it's a high-risk patient. You can start at about 5 milligrams. All right, and then if they're still having pain, another milligram, another milligram, another milligram. The question is, why is morphine, or in some settings now I see they're moving away from morphine and more towards tranquilizers and things like. It's important because it controls pain. All right. And the other thing, it decreases catecholamines. Catecholamines are adrenaline, cortisol. All right. Stress hormones. Okay. So what stress hormones do is they make your heart beat faster and harder. Now here you have a damaged heart. Okay. So to give you an example, again, let's say the right hand, we've cut off blood flow to it. And adrenaline and cortisol are the equivalent of taking this damaged hand and now picking up 20-kilo dumbbells. And you're trying to do that to a damaged hand. What's going to happen? It's going to run out of oxygen faster, and it's going to make the muscle, let's say the muscle ischemia, happen faster as well. So it's the equivalent now of putting down that 20 kilogram dumbbell. There's still not enough flow, but at least you're not accelerating the damage as well. Do you get what I mean? Okay, right. If you don't, it's fine. You must tell me, I'll stop. Okay. So these patients need urgent reperfusion, all right? So they need to get everything going. So this is the point where you normally involve your physicians. Now, depending on where you work, some places thrombolize in the emergency department. Like in our case, they prefer to do it in ICU. So it just depends on where you work, all right? So generally, these patients, we don't wait for the cardiac enzymes. The reason being, cardiac enzymes don't actually go up for the first 6 hours. So you've got a patient, they've got an acute problem. If you take your cardiac enzymes, they look normal. But if you do your ECG, it looks extremely abnormal. So you actually have to go, you have to actually go by the ECG, all right? So what do I ask the patient? All the thrombolytic indications, contraindications, things like that, all right? So that's a whole list on its own. And how do I present the patient to the physician? Exactly like that. I've got a high risk anteroseptal plus high lateral MI. The vitals are this. This is what we've done so far. Think the patient may need ICU and thrombolysis or PCI, and allow them to take over. Okay, that's where we go. All right. So what are the ones that are considered high risk? ST elevation or new left bundle branch block. All right. Now, if you can't remember left bundle branch blocks, don't stress. We'll get to them in a few weeks' time. All right. Strongly suspicious for injury. All right. So we start the therapies as we had mentioned, do not delay reperfusion. All right. So if the time of onset of symptoms is less than 12 hours, then we try and do PCI or thrombolysis. All right. Beyond 12 hours, then that's a different thing, but we're not going to get into that right now. Okay. All right, so that's one section done. Interpreting the ECG, well, these are just the things that we normally do. We interpret axis, rate, rhythm, and then we look for changes in abnormalities. Okay, so let's try some, and you try and name where the problem is. All right, so in all of these, we're just going to assume we've done the axis, the rate, the rhythm. We're just looking at where the infarct may be. So where do you think the infarct may be? Looking at that. So yeah. Sorry? Yeah, but which section of the left ventricle? So V1 and V2 look at the septum. So do you think the septum is involved? Okay. V3 and V4 look at the anterior part of the heart. Do you think that's involved? Okay. V5 and V6 look at the lateral border of the heart, not the high lateral border, just the lateral border. Do you think that side is involved? Not to such a great extent. Agreed. There is a little bit of an ST depression, but that I suspect is how they place the lead rather than it being. All right, let's look at the inferior part of the heart. What do you see on leads 2, 3, and AVF, which are the inferior leads? They look at the heart from the bottom. ST depressions, all right, or reciprocal changes. Okay, so reciprocal changes to remember. Let's say you are standing here, all right? Let's say you are standing here in front of me, and I push you. I will see you moving away from me, but he will see you moving towards. Why? Because he's on the opposite side. So that's the same thing that happens with reciprocal changes. What's happening on one side of the heart, the other side of the heart sees the opposite of it. Understand? Not really. Sort of. A bit confused. Okay, so let's try and work in it this way, all right? So this is the inferior part of the heart, for example, all right? So have a look at what I'm showing you. So this is the inferior part of the heart. Okay, this is the lateral side, anterior side, things like that, right? So let's look at the high lateral side, 1 and AVR, because it's the same one we saw before, right? So look at that and look at that. Aren't they kind of opposite to one another? If the leads are here and the leads are here, they're looking at the heart from different directions. So this lead, the high lateral lead, is seeing an ST elevation, like what we see here, right? On 1 and AVL, we see an ST elevation. So leads 2, 3, and AVF are also seeing the damage that's taking place, but it's seeing it from the opposite side of the heart. So it's seeing a depression, and that one is seeing an elevation. So that's what a reciprocal change means, all right? So if you don't see a reciprocal change, it decreases the chances of it being an ischemia, okay? So this is actually the one we saw before. It's the same thing, just with a few added lines, all right? So it is a anteroseptal with high lateral and reciprocal changes, okay? All right. Let's try this one. Okay, where do you think the problem is? So let's look at the septum first, right? V1, V2, what do you notice? Yeah, there is an elevation there on V2, and V3 and V4, the anterior part of the heart. Slight elevation, yeah. And what do you notice about the T waves all here? Yeah, inverted T waves, very good. Okay, let's look at leads 2, 3, AVF, the inferior leads. What do you notice? Nothing much, isn't it? They kind of look normal. And if you look at 1 and AVL, also, they look kind of normal, right? AVR also looks normal. So the question is, if we have what look like ST elevations, but no ST depressions, the chances of a myocardial infarct are less. All right. That doesn't mean we discount it completely, because if this patient came with chest pain, we still got to work them up. All right. But this is not a patient that you're going to rush to ICU and thrombolyze. You're still going to wait on your markers. You might admit them and have a look at them. And the thing is, V2 and V3, they have a little peculiarity about them. Okay. The non-specific T wave inversion is also something that we have to worry about. In this case, V2 and V3, there's just a bit of a special consideration. In female patients, if you have ST elevations above 1.5 blocks, it's worrying, all right? But less than 1.5 blocks, it's nothing to worry about. It's something called benign early repolarization. It just means the heart contracts a bit quickly, but it's benign. It's nothing to worry about. Okay. And then if in male patients, if it's more than 40 years old, 2 blocks, less than 40 years old, 2.5 blocks. Now you won't remember this in a week or two. All right. But I want you to remember that there's something about V2 and V3 and the age. And in this day and age, just Google it. All right. Say how many blocks for V2 and V3 male patient. And all of this will come up. There'll be hundreds of websites telling you exactly this. Okay. So don't stress about it. But just so that you have it at the back of your mind. All right. Let's have a look at this one. So where do you think the infarct is? Now I'm not holding your hand. You all need to tell me. Go through it in your own mind. First one to answer wins my sympathy. No, very good. Yeah, there you can see 2, 3 AVF. You can see that. Where's your reciprocal changes that you can see? See there? See there? That's your reciprocal changes. Okay, because now remember the infarct is happening here. So the one on the other side is now seeing the reciprocal change. All right. So this is quite an inferior infarct. How do these patients present, by the way? Do you know? What will they come with? Because they don't come with chest pain, they come with stomach pain. All right. Because the stomach is lying just below. There's just a diaphragm separating the heart and the stomach. So if anybody comes with stomach pain, severe stomach pain, just do an ECG. It may turn out to just be stomach pain, but no, epigastric and all of that. So at least you can say, listen, I at least excluded a myocardial infarct, because if the patient, something goes wrong later on, like, they perforate a peptic ulcer or something, at least you can say, what, I was trying to look at everything. Okay. And sometimes you will pick up these things as well. Okay. So this is an inferior, all right? Now we need to know if inferior is also going to the right-hand side. So as a rule of thumb, this is lead 3, this is lead 2. If the ST elevation in lead 3 is higher than lead 2, then we say it's not just the inferior portion, it's also the right side of the heart that's affected. Okay, so we have to do a 15 lead ECG. It's also known as an anterior 18 lead to confirm. All right, so that is when we just take all of the leads and switch them around. All right, normally they would be on the left chest. Now we put them on the right chest. That's all, because we want to look at the right side of the heart. We don't want to look at the left side of the heart. And then once we have a look at that, then we can see the ST elevations on the right side of the heart. Okay, and these are patients you don't give TNT to. All right. All right, any idea what's going on here? This is a bit more of a harder one, but even if you get one part of it, I'll be happy. Very similar to the last one. Okay, so when you start with the inferior leads, what do you notice? ST elevations. And you come here, what do you see? Very good. When you come there, what do you see? Depressions, isn't it? ST depressions. Okay. So basically what you are looking at is you are looking at the myocardial infarction plus all the leads that are across from it that are seeing the opposite. Okay. So you can quickly pick out where the problems are, especially for MIs. You must be able to pick it out a little bit quickly. Okay. Now, this one here is actually a special one because it's also a posterior myocardial infarction. Now, if you can't diagnose that, don't stress about it, all right? I'm just showing it to you for interest's sake, all right? Now, diagnosing a posterior MI is quite common when we have an inferior right because the blood supply is all similar as well. Okay, so this we confirm with an 18-lead ECG. And the 18-lead ECG, we put V4, V5, V6. We just take them and move them to the back to look at the back of the heart. And then we call them V7, V8, V9. And there we see ST elevations. So that's how you look at a posterior MI. The reason why I say this, you'll be walking around with some arrogant physician one day who wants to make you look stupid. I promise you. And you'll say, right, do a posterior 18-lead ECG for me, go find the machine. And they'll make you run around like an idiot looking for a special 18-lead ECG. In the meantime, all they want is for you to put this at the back. And that's when you can tell him or her, no, sir, no, ma'am, I know how to do it. And they'll be like, oh, what do you mean? Yeah, I was supposed to have fun with you today. I hate you now. No, the same ones. So V4, 5, and 6, we just move them to the posterior axillary line. Where V7 is, that's where you put V4. Below the tip of the scapula, you put V5 or now V8, and just paraspinal, you put V9, what was the old V6, okay? And for the one on the right chest, all that you do is you take V3, V2, V3, V4, V5, V6, and you just do a mirror image on the other side to look at the right side of the heart, okay? All right. So we're going to look at an NSTEMI, all right? So a non-ST elevated MI, or where you only see ST depressions, all right? So we want to worry about whether our patient is high risk or low risk, all right? So sometimes you get ST depressions, or you get patients who present you with unstable angina and things like that. So the way that you would figure it out is that they only have ST depressions. There's no ST elevations, all right? So that's called an NSTEMI, all right? The other thing that happens is dynamic T wave inversion. That means your T waves become deeper, they become wider, there's a lot of things, all right? Or it's just strongly suspicious for ischemia. And for some patients, what happens as well is that no matter what you are giving them, they still have chest pain, all right? If you do another ECG for them, the ST keeps on moving around. It's not in the same place. Okay. They have a tachycardia, low BPs, they're going into heart failure. These are patients that you know are actually worse. Okay. Now, don't stress if you can't remember all of that now, because the important thing is it's not difficult to actually tell. All right. Let's say you've got an NSTEMI patient who comes in. BPs are 80/30. They're screaming in pain. They're not even talking to you properly. You can see their lungs are filling up with water. You're not going to sit back and say, it's an NSTEMI. You must realize, listen, there's something going on. I need to elevate this. All right. But you guys, luckily at yours level, you don't need to know all of that. You know, you don't need to stress about it, because there'll always be somebody who's supposed to be with you, you know, and who's supposed to be teaching you, all right? So if the patient is unstable, they become high risk. If there are dynamic changes, in other words, the ECG keeps on changing, ST depressions become worse, T wave inversions become worse, QRSs suddenly become wide, things like that, then we know that this is a high risk patient, all right? If you do your initial TROP-Ts and CKs and they are high, that's also a high risk, all right? And basically what we're asking ourselves is, our patient deteriorating in our care? So are they getting the same things? Tachycardias, heart failure, persistent pain, low BPs. Then you know, okay, this patient is not just a simple angina. This patient is actually a high risk patient. And they treated exactly the same, all right? All right, so then you manage them exactly like how you would manage a proper infarct, all right, a STEMI. You never send them home, okay? You don't ever say, go home and we'll call you when your results come out. You need to have a look at them, all right? And they must have serial ECGs, cardiac markers. The one big difference is we don't give them as much morphine. So you would remember with the STEMI, we gave up to 10 milligrams. With these guys, we only give them 2 to 5 milligrams, all right? And that's also is only if TNT under the tongue is not controlling the symptoms. Now, there's a lot of reasons why, but the one reason to remember is that they found that giving high dose morphine in this actually causes a high mortality rate. Okay, there's a whole paper about why, and that's a whole discussion on its own, all right? And then you have the low risk patient. In other words, it sounds like cardiac pain. They're having chest pain. ECGs are normal. Cardiac enzymes are normal. Everything else is normal, but they're insisting that they have chest pain. All right. So for example, you have a young, active white lady, the lowest risk for cardiac disease in our country. All right. But she comes in and she's insisting, I have got, you know, she does triathlons every weekend. You know, she only puts soya milk in her rooibos green tea. Do you get what I mean? Those types of patients, they come in, they're healthy, they fit, but they're insisting they've got cardiac pain. The question is, have I considered alternate diagnosis? So what are the alternate diagnoses? There's a lot, but the most important ones, pericarditis, all right? Infective, non-infective, autoimmune, TB. There's so many that it can be, all right? A dissecting aneurysm. All right. So in other words, your thoracic aorta can start to dissect. All right. And that can be from a congenital malformation, genetic problems. There's quite a bit of things that can cause it. Esophageal rupture is maybe a bit extreme. Let's say esophageal tears. All right. They call Mallory-Weiss tears and things like that. And esophageal rupture is generally quite a big emergency. All right. The patient's bleeding, they're vomiting blood. That's quite bad. But a Mallory-Weiss tear is basically like thin tears, linear tears along the esophagus. So they may also be coughing or vomiting up blood. All right. And then a pulmonary embolism, okay, or even a pneumothorax can all lead to chest pain. And sometimes it can just be muscular pain. All right, like I said, this lady's been doing triathlons every week. Maybe her body's just tired. You get what I mean? But that's a diagnosis of exclusion once you've excluded everything else, all right? But if you are strongly suspicious of a cardiac cause, in other words, you don't find anything else, but this pain is just persistent, then you admit these patients. Serial ECGs, serial cardiac markers, because something may show up in the second ECG or the fourth cardiac enzyme, they may start noticing a trend of the TROP-Ts going up. So they know that something is going on. Okay. Some of these patients also have other conditions like atrial flutter, for example, different types of ventricular abnormalities, intermittent SVTs that can also cause. So there's a whole lot of things, don't just say, okay, and I didn't find anything, go home. That's basically the thing. Okay. So just a few last things that we can notice on an ECG, all right? So this we had seen in one of ours. This is called an inverted T wave, all right? So that's a normal T wave, and this is an inverted T wave. So inverted T waves are non-specific. They're non-specific for ischemia, but they start, especially if the patient has chest pain, you have to start thinking, could this be an ischemic event? All right, very good. And I'm sure you've heard, is this a pathological, have you heard of Q waves and pathological Q waves? All right, Q waves are normal. Small Q waves that come before the QRS complex or in the QRS complex, those are fine. But once you start getting deep, wide Q waves, that's what we call a pathological Q wave. All right, so a pathological Q wave tells us that there's been ischemia in the heart. The only problem is it doesn't tell us when. Could have been 10 minutes ago, could have been 10 years ago. You get what I mean? So a Q wave, that's all that it tells you, but this is what it looks like, deep and wide, okay? All right, then we have tall T waves, all right, which is another one people see, all right? So this is hyperkalemia. Now I'll give you a way to remember it that you won't forget, all right? It's a bit rude, but you will remember it for the rest of your life, all right? So hyperkalemia, very thin and pointed at the top, all right? Hyperacute ischemia, in other words, the heart attack happened now, a few minutes ago, all right? You may not get any other changes besides these tall, broad, symmetrical T waves, all right? Very tall. I mean, look at the QRS complex, and this thing towers above it. And then you get this type of a thing, which kind of slopes up and then quickly slopes down. That's just a normal variant, all right? So the question is, how do you remember the difference between all of these? Very easy. Hyperacute ischemia, if it was a dildo, you wouldn't mind sitting on it. It looks quite comfortable, agreed? Hyperkalemia, if you sit on this, it's going to tear your insides up. All right, you'll be taking a chance. Sorry, I know we have a lady present, but I assume you know what a dildo is. All right, and this one here, the normal variant, depends, maybe on a good day. All right, it's not going to tear me up, but it doesn't look that comfortable either. All right, so now you'll never forget it. All right, yes, I would be happy with this dildo. Hyperacute ischemia. Oh God, this thing is going to kill me. Hyperkalemia. If I was all right and if I think I could manage it, normal variant. Okay. Ever going to forget it? No. All right. You'll be on your deathbed and say, hey, hyperacute ischemia, normal dildo. So I just want to show you guys a special case, all right? So very rarely, sometimes like once or twice a year only. Now remember, we haven't talked much about AVR, the one that sits on the right-hand side, all right? It's called the forgotten lead because there's very few uses, all right? It's just looking at the right-hand side. But there are sometimes patients who come in with chest pain that subsides, and then they only have these ST elevations on AVR. They may not even have any reciprocal changes, all right? If that type of a patient comes in, it's actually very, very warning, all right? Isolated AVR ST elevation signifies a main stem blockage. In other words, it's at the level of the aorta. So there's something blocking the coronary arteries right at the level of the aorta where they come off, all right? So it's quite severe because that means there's no blood reaching large parts of the heart, okay? And whereas the others tend to happen further down. So, you're still getting blood flow across and around, there's collaterals and things like that. But here it's at the main part of the arteries that are branching off, all right? The other thing is it can just show the left anterior descending artery, but right towards its beginning, right towards its root. So this thing has a 75% mortality rate when treated. In other words, a patient comes in, we pick it up and we send them for treatment, 75% of them will die. So imagine what happens if you don't pick it up. That starts to approach 100%, all right? So it's not something you're going to see very often, but if you see it, get worried. The problem is these patients are often pain-free after the initial symptoms. The reason being, there's no blood. So there's no blood going to the nerves either. They denervate, ischemic denervation. There's nothing. So that nerve is dead. It's not going to send any signals back to say that I'm still in pain. So the patient has, and I'm okay. You know, I think it was just heartburn or something like that. But in the meantime, they are having a problem, right? Now, this is just for fun. Okay, please don't stress about remembering these. This you may see like once every 5 years or something like that. You get these very specific type of T waves, biphasic T waves in V2 and V3. Now, this is something called Whelan's phenomenon. There's a few types of them. But it's just for fun, just to show you that even sometimes a simple thing like this looks very innocuous, but your patient has chest pain and you can't find any other cause. You know, just go ahead, just check and see what you can do. Do their enzymes, admit them, see what's going on. All right. So I don't know if anybody wants to take a chance with this. This is looks scary, yeah? Yeah. So any idea what's going on? This patient has chest pain, severe chest pain. Yeah, I know you're not my employees, but I'll call you an employee of the month. People on Zoom as well, if you want to, you can also take a guess as to what it is. So let's be systematic about it. All right. So let's first look at the axis. So we look at the axis. We've got lead 1, AVF, both pointing upwards. All right. So we know that we've got a normal axis. Let's look at the rhythm. Now let's. Sorry. Actually, it has. You see, it's got a a QR. All right. So ST elevation means from there it would come up. All right, and then carry on. But this is actually quite normal for it. But I understand why you thought it. All right. So this is actually a ST segment, this downsloping. If it was an ST elevation, it would carry on like that. And then you'd get your T wave. Okay. So let's look at your rhythm. Do you have any P waves? Anywhere in the body? Yeah, not really. Eh? Hey? Yeah, unless you go right here. There's some P waves over there, all right? Small P waves, but they are there, all right? And then there's 1, 2, 3, 4 blocks within normal. QRSs are narrow, which is normal, and they're relatively regular, right? But the rhythm is not the important part here. And let's take the rate. The rate is going to be 150 beats per minute. So it's a tachycardia, quite a severe tachycardia, all right? And then what do we see? Let's look at the inferior part of the heart. 2, 3, AVF, what do we see? Does it look normal? That's the first thing I'll ask you. From all of the ECGs you've seen so far, does it look normal? People on Zoom are welcome to answer as well. Don't worry about this. This is just an ectopic beat, all right? So take that out of your head, don't worry. Yeah. All right, no problem. Let's see leads 1 and AVL, the high lateral. What looks, does anything look abnormal? Tough, huh? It's tough, I know. What's happening in V1 and V2? What is this called? Any idea? This M shape in V1 and V2? It's called a right bundle branch block. All right. That's a right bundle branch block. V3, V4, V5, V6. So no ST elevations, no ST depressions. What are you going to do for this patient? She's complaining of severe, or he's complaining of severe chest pain. You have to take more history, all right? So you're going to ask them what else is going wrong. Let's say he says, you know what, I was coming here, I was sitting in a taxi for the last 8 hours. We were all stuck. And eventually when I got off to stretch a little bit, and after that, I just got a whole lot of chest pain. What do you think might be going on? What would you start thinking of? Very good, pulmonary embolus, all right? So you may start thinking about that. Now, I'll give you employee of the month, all right? Because you got the answer right after a lot of hinting, okay? But this is a pulmonary embolism, Why I put this here is because generally we think it's only MIs, STEMIs, things like that. No, there's lots of things that can cause chest pain. Now, there's a whole different talk on pulmonary embolus, but this one here has some features: tachycardia, tachycardia, right bundle branch block. Then you will hear this through your exams and through your rounds as well. S1, Q3, T3 pattern. What does that mean? It means in lead 1, you have an S wave. This is an R, S. Can you see it's a deep S wave? All right. And then Q3, can you see you've got a Q wave in lead 3? All right. And an inverted T wave in lead 3. So S1, Q3, T3. That's what it stands for. All right. T wave inversions in the anteroseptal leads. All right. So that means up till V4, as well as the inferior leads. All right. Now that one there is actually 95% specific for a pulmonary embolism. So even if you forget everything else, but if you remember V2, V3, V4, V1, T wave inversions, plus here in 2, 3, and AVF, T wave inversions. Okay. Then you can almost be guaranteed that it is a pulmonary embolism. You do get right axis deviation not seen here. And like I said, there's many more signs, but when we tackle pulmonary embolism, I'll go through that whole thing. All right. Okay. So at the very least, you can get an ECG, stratify your patient, and you can start the process of saving the patient because you get the right people involved. All right. So just as long as you can recognize abnormal from normal, then you know you're doing okay. You learn all the diagnosis as you go through. All right. One day you may end up as a radiologist. You don't need to know ECGs in depth, you know what I mean, or a dermatologist or something like that. But if you end up in anesthesia, even surgery, you know, medicine, of course, you know what's the most dangerous thing in the world though? An orthopod with an ECG. Yeah. Why does an orthopod wear a stethoscope? Eh? No, because his friend gave him one. Okay. All right. That's just a joke to finish off. So we covered quite a bit today. All right. It was really quite a bit. And it's a lot to take in, you know, but it's just to give you more what's important is to understand that there are different levels of chest pain. There are different diagnoses of chest pain. The ECG is very important. And the thing is, it is life-threatening. A lot of those things are life. Pulmonary embolus is life-threatening. Pneumothorax is life-threatening. Okay. Pericarditis is life-threatening. So even amongst your differentials, you've still got life-threatening conditions. So chest pain, you've got to take it seriously. Okay. The mild diagnosis, if I can put it that way, or non-life-threatening diagnosis are by exclusion. You don't walk in and touch and say, oh yeah, you definitely got costochondritis because it feels like it when I touch you here. That's not how you diagnose it. You get what I mean? You have to do everything systematically because sometimes these things can be very subtle. Right? Do you guys have any questions? Even those on Zoom? Everybody. Shame. All right. If there's no questions, I hope you'll enjoyed it. And I know today's was a little bit more intense than what we normally do because I had to cover a whole topic. You normally spend a month on this when you're becoming an emergency physician. And if you're a physician and a cardiologist, you go through these every day. All right. So you try to cover a lot of stuff in just a little bit of time, but just to give you all an introduction to how chest pain works. Okay. As far as radiation and where it goes, forget about the whole left arm, left jaw thing. That's actually the least common presentation. Right. The right shoulder is more commonly affected than the left shoulder. Headaches are more common than jaw pain, for example. Epigastric pain is more common than heartburn, for example. Right. Crushing chest pain is one of the more common symptoms, but not necessarily as well. In diabetics, they may have no symptoms at all. You know, so there's all of these things that go along, but always treat it as best as you can. Okay. All right, and in that case, since I taught it so well and there's no questions, I'm going to end it there and we're going to get back to work. Okay.